The gastric bypass is the gold standard operation in the United States today, and I've been doing the gastric bypass since about 1987, when it was the sort of new operation on the block and gradually replaced stomach stapling. It's done by cutting a small pouch out of the top part of the stomach that reduces the reservoir capacity of the stomach from about 1 to 2 quarts to 1 to 2 ounces. That little pouch is hooked up to a limb of intestine that connects again with the bypass stomach to create the two limbs of a Y, hence it's called a Roux-Y gastric bypass. The small pouch means that a patient eating will feel full sooner. The opening out of the pouch is sized carefully as it's connected to the intestine so that patients have to chew more carefully. What also is a byproduct of this operation is that by bypassing the stomach, when the food stream bypasses the stomach, it results in the non-production of a hormone called ghrelin that makes people feel hungry and typically cycles up and down during the day 2 or 3 times and causes us to eat. When the ghrelin level remains close to 0, as it does after a gastric bypass, people lose their appetite, and there's a very profound loss of appetite for a year or so after gastric bypass. We find that most patients really don't care. They have to remind themselves to eat for 8 or 9 months. And typically what we see is a rapid weight loss, and after that period of time it's more or less easy to stay where the patient wants to be. You would notice, if you were a patient, that your hunger for sweets, for carbohydrates, all of those things would largely have gone away. You would have to work at it to get that hunger back again. And that's the only way that you really can fail long-term at a gastric bypass, is by sort of redeveloping an appetite for the bad habits that you had beforehand. So after the 8 or 9 months with a 100 to 200 pound weight loss, you can expect as a patient to have a relatively easy time maintaining your weight. But you've got to be careful not to undermine it with introducing bad habits again. Gastric bypass, I may suggest to a patient who has high blood pressure, diabetes, a severe degree of overweight, as a means of rapidly reversing diseases that I think are life-threatening over relatively shorter periods of time. That said, it's also the only operation that produces rapid weight loss that's covered also by insurance companies. Sleeve gastrectomy produces a lot of weight loss, but it's not covered by the insurance companies the way the gastric bypass is. With gastric bypass, weight loss is very rapid, occurring in the first 8 to 10 months after surgery, and amounts to about 80% of excess weight loss in our experience. And so if you were 100 pounds overweight in that period of time, you would typically have lost 80 pounds. If you were 200 pounds overweight in that period of time, you'd have lost 160 pounds. At that point also, weight loss tends to stop, and it becomes more the responsibility of the patient to maintain weight loss and the same sort of maintenance of and attention to diet and exercise that most of us make. The short-term operative risks of gastric bypass are bleeding, for the most part, or infection from leakage. Those are big risks if you have them, but at the same time, the overall risk is with a gastric bypass is substantially less than the risks of being morbidly obese and diabetic and hypertensive and the sorts of things that go along with being in a weight category where you would choose to have this kind of surgery.